Start your presentation.
Hello. Hello, I hear. Good morning. My topic is surgical challenges of approach in addressing transitional cervical cervical spine. Nešto mi je zakočio. Okay. Modern lifestyle has led to significant increase to incidence of cervical spine diseases. However, today the diagnostic of spine diseases is more quality or faster. Adequate approach to treatment of timely diagnostic could become important, achieving a good outcome in the management of cervical spine disease and prevention on complication. What is the stability of the spine? The stability of the spine is viewed collection on independent functional dynamic unit. Spine stability consists of mechanical or neurological stability. Mechanical stability is adequate capture of physiological and absence of pain or deformity. Neurological stability, absence of damage or irritation of nerve elements. Mechanical instability could be dynamic instability and static instability. Dynamic instability is deformities of changing attitudes, spine elements occurring during physiological moments, and subacute gradual process to development of the margin bone ligament structure. Static instability we see in reanalysis of appropriate distance and CT analysis of articular system and NMR analysis of the posterior ligamental complex. Mechanical instability have accept standard, offer 15% of loss high of injury PLC and offer 30% kyphosis with injury posterior ligament complex. NMR visualization demarche PCLC and standards applicable for any clinical manifestation with or without neurological deficit. Disruption of mechanical stability of the spine direct affected the neurological stability. Basic pathoanatomical process and the march of cervical spine is degenerative cervical compression, post-traumatic cervical compression, tumors procession of the spine column and neural elements, inflammatory process of the osteoligamental structures, osteomyelitis. The regional structure of cervical spine is very complex with regards to its morphological and functional characteristic. It's divided into three segments: cervico-occipital, central, cervicothoracal segment. Resolving pathological process in this corresponding segment is directly related to the surgical reconstruction of the mechanical and neurological stability of pathological altered segment. Cervico-occipital segment consists of the atlanto-occipital bone ligament structure, atlas bone ligament junction C1, C2, axis bone ligament junction C2, C3. The basic surgical principle in this segment is the application posterior mechanical stabilization, all combine anterior and posterior stabilization, and only rarely the anterior stabilization. The basic principle is the preserved local stability, achieving maximum mechanical stability. We prefer occipital cervical fixation with C1, C2, and the occipital cervical fixation with C3, C4, and C5. In case tumor occipital cervical transition meningioma, we surgical approach lead to mechanical destabilization, removal of bone and ligament structure in the latter parts of C1 and C2, providing high quality visualization of tumor process, and postoperative measure complete tumor removing and removing atlanto-axial joint. We using in this case cervico-occipital stabilization. Degenerative basilar elongation of the odontoprocessus into medullary rheumatoid arthritis. We must complete removal of the atlanto-occipital junction, laminectomy C1, laminectomy C2, partial disarticulation C1, C2, bilateral libellation on arteriovertebrae, and cervico-occipital stabilization with distraction. In this case, we have a very, very good recovery. In a pathologic fracture of C2, it is necessary to ensure mechanical stability. This is plasmacytoma, and we must have mechanical stability for future therapeutic procedure, chemotherapy, oncologic therapy, and this same case, multi-destruction process C2, C3, C5, plasmacytoma. In this case, we prefer anterior and posterior stabilization with corpectomy. Fractures of dense and articular processus C2, C3, stabilization, dissection posterior, massive decompression in this region. This interesting case indicate fracture dense indicated only Philadelphia color in second hospital. Wrong decision, and we have three months after injury mechanical and neurological destabilization, and we prefer in this case transpedicular C1, C2 stabilization. Fractures dense. In this case, we prefer anterior scroll fixation on odontic procession, coagulation. Same case. In this case, fractures and instability C3, C2, C3, mechanical neurological instability, and prefers only a posterior stabilization. This is interesting case. We have 3D instability, mechanical and neurological instability, bilateral fractures, articular mass, and we prefer anterior and posterior stabilization in this case. Cervicothoracic transition is very specific and very difficult segment for a surgical approach. Why? Functional rigidity of the cervicothoracic junction, anatomic specificity of the bone structure position, complexity of 3D surgical approach. Cervicothoracic segment including level for C6, C7, and TH1, 2, and 3. We have stabilization for fractured cervicothoracic spine and stabilization spine after surgery pathologic processes. We prefer 4 surgical principles. First surgical principle is complete removing of the pathological process on the replacement of the bone structures by auto or allo material. Second surgical principle enable complete decompression of nerve element in affected parts of the spine canal. Third surgical principle achieving adequate correction of the cervicothoracic curve will preserve cervical lordosis. And fourth cervical principle, good stabilization without the possibility of post-operative static disorder of the spine. This is interest case, the 6-year-old fractures, C4, C6, C7. We have neurological instability. And in this case, we prefer first posterior approach, complete elimination of the bone block, anterior approach with reconstruction and corpectomy, and posterior reconstruction cervicothoracic curve. Polysegment tumor process, C7, TH3, intracanalicular and extravertebral. Massive process in the postoperative after 1 year, but we have instability in this region, and we must reoperating and fixation this region. Post-pathologic collapse T1. In this case, we prefer bilateral postolateral approach with the T1, T2 rib resection, transpedicular fixation of T1, T3, and C7, and the transarticular fixation of C6 and C7. Only posterior approach. Flexion rotation fractures of the C6, C7. In this case, we prefer anterior and posterior reconstruction. In this case, we have unilateral rotation and fractures. In this case, we prefer only posterior stabilization. Compressive fracture of C7. anterior approach and posterior stabilization, preserve curved cervical thoracal. And this case, massive tumor process, massive destruction, elimination tumor and stabilization. In the tumor T1, bilateral costal transversectomy and corpectomy, only posterior approach and reconstruction in this region. In most cases, tumor processes in cervical spine accompanied by loss of neurological and mechanical stability of cervical spine. Providing adequate mechanical stability is of critical importance after removal of a tumor process. Stabilization must be direct towering, ensure complete stability not only of the segment remarked during surgical work, but also to neighboring ones. Inadequate correction of mechanical instability doesn't not result in adequate neurological recovery of the adequate function of the spine. Application of 3D reconstruction approach in resolving pathological change in cervical spine has direct impact for better quality of speed of the post-operative recovery as well as reduction the level of residual neural damage. Thank you.